the it also helps in grouping the similar entities in different syndromes, basically, which helps in management of epilepsy and counseling of the patient, basically. This classification is being there since 1981 by International League Against Epilepsy. Recently, in 2007, they have published the updated classification of seizures and epilepsy. Second session, sir is going to talk, having a video quiz, which all you will enjoy definitely. And this 1 hour presentation will be followed by question and answer. You can continue to write answer during the presentation. So I request Udani sir to start his presentation.
Good evening, everybody. I hope everybody is safe in the lockdown. I think it's a little odd to be talking to an audience without actually seeing them, and I've had this problem in the past. I'm talking and I'm not sure anybody is hearing me or whether I'm clear or whatever. So please, if my videos stop or if there's any issue, please interrupt me and tell me. I would. The first part is classification of seizures and epilepsies, which occurred in 2017, as Sanjeev told you. And there's a lot of changes which I'm going to tell you about and going to illustrate with some examples and some questions. And there are some questions at the end. And the second part I will talk to you about that when I come to that. So I just think I'll start talking about this classification. Okay. Can you see?
Yes, sir. It's perfect.
Yes, Dr. Udani, it's pretty clear. You can go ahead, doctor.
Yeah. So this is I was told the audience is mainly pediatricians and of course many trainees, and I thought that I'll be a little basic at first, and then maybe later on we might go a little bit higher in the grade of difficulty. Oh God. So first, let's see the definitions of a seizure. Everybody's clear about it. I don't have to spend much time, but this is the 2005 definition by the ILAE. It is fairly standard. Epileptic seizure is a transient occurrence. It's a paroxysmal episode. Signs and symptoms could be anything. And the third part, the abnormal excessive synchronous neuronal activity in the brain, is very difficult to tell clinically, obviously, because we don't have EEGs. We usually don't have EEGs during the time of the episode. So we have to decide mainly on the clinical context and history, and has to be from a witness. So always remember, the witness is most important with the diagnosis of epilepsy. Now, epilepsy is a disease. It's basically now classified as a disease. And it is basically defined as, this was in 2014, this is the operational definition, so which can be used in the clinic. If you have two unprovoked or reflex means you get a seizure due to some stimulus. So two unprovoked seizures occurring more than 24 hours apart. I'm sure all of you know this very well. And then the new part is the one unprovoked. Even if you have one unprovoked seizure or a reflex seizure, and using imaging, using EEG, you come to a probability that further seizures are going to occur maybe at least 60% of the time over the next couple of years, then next 10 years actually, you can call it epilepsy. So epilepsy is now not only two clear episodes of seizures 24 hours apart, it can be only one with say you have some sort of lesion, or you have abnormal EEG or whatever it is, you can call it epilepsy. The treatment part is still, of course, up to different reasons. So you're not talking about treatment, but you can call it epilepsy. And the diagnosis of an epilepsy syndrome, even with the first seizure. So for example, you have a first seizure in a child who has benign Rolandic or benign epilepsy with sensotemporal spikes, and the EEG is typical of that, you can still call it epilepsy. And the next thing which has come up also is resolved epilepsy. So resolved epilepsy is now, we don't call it cured, because epilepsy cannot be really cured. It can be helped, it can resolve. So what is it? Is considered to be resolved for individuals who had a age-dependent epilepsy syndrome. Say, for example, like we go back to the same example, benign epilepsy with sensotemporal spikes, usually by 15 years of age, it goes away. So by 15 years of age, you're considered resolved. Or those who have remained, and other types of epilepsy, seizure-free for at least 10 years. And of those 10 years, there should be no medication for at least 5 years. So if you go at, why this 10 years, how did they come to this? It's basically not really scientifically, but the expert consensus that 10 years is a long time. And most of the time, if you cast 10 years, your risk of seizures declines dramatically. The other thing which has changed in the concepts is the epileptogenic focus. So everybody is familiar with this, a lesion which is surrounded, which is probably a cystic circus, which can cause epilepsy. And this is, it is assumed that this was the area only which was responsible for the epilepsy. And then in the 90s, the epileptogenic zone, 80s and 90s, we thought that the seizure is not only where the seizures arise, but also in that area next to it, which was essentially potentially can cause seizures. And if you have to do surgery, you should have to remove this entire part, and therefore it was called the EZ, or the epileptogenic zone, and this was the local network. Now we know that there's a lot of connections which occur, and this is the epileptogenic network. Now this is the last 10, 15 years, this is exactly what we understand. So let's go back to that lesion, the cystic circus, for example. Then you have a local network, which is called the epileptogenic zone. It is represented by certain types of EEG changes, which we are not going to go into. Then there's a propagation network. So a seizure usually has of maybe one, maybe many propagation networks where other critical areas, not critical, but at least nodes are involved. And these are represented by a different type of EEG. And then there are non-involved networks. How is it important? Because this explains why even after you remove the lesion, you remove the epileptogenic zone, many children, even after surgery, come back with seizures years later. That is because the other parts of the network might start activating. And this is just a cartoon illustrating that. So this is a generalized bilateral network. So when you have a bilateral network, it goes from one side, it starts all over the place, but it doesn't start from one place. It just involves bilateral networks. And focal is, if you have starting here on one side, either crossing over to the other side or, spreading regionally. So that's a focal network or unilateral network which spread. Now going to the classification of seizures. These were the old classifications that were given up a long time back, and all of us are familiar with the 81, which Sanjeev mentioned. It was based on video EEG, and there were these funny terms called partial and complex partial and all this partial with secondary generalization, which were quite confusing, especially in children, because you really didn't know whether a patient was conscious, not conscious, and other things. And I think the last almost 40 years later, 37 years later to be 36, 37 years later, we have a new seizure classification where you have basically divided into a focal onset seizure types, generalized onset, and a very important term, the unknown onset. And then after that, the generalized onset, you don't bother about awareness. The consciousness is removed and now you're aware or impaired aware. Then you have motor onset or non-motor, and then you have focal to bilateral tonic-clonic. So I will just remember this. I will explain a little further. Generalized onset, you have either motor or non-motor, and the most important is the unknown onset. So we are realizing there are a lot of things we don't know, and those are also motor and non-motor. And then there's the unclassified. That's completely, we don't know what's happening at all. So this is based on clinical EEG and imaging. And the most important thing is you can use a basic classification if you're a general practitioner, or you could use an advanced classification, which I will come to you. So let's come to the basic classification. What are the rules and what are the changes? So focal and generalized only if you're reasonably certain We're 80% sure that it's focal or generalized. Otherwise, you call it unknown. What is part of the seizure which is considered? The onset. So whether it's focal or generalized or unknown depends on the onset. You must know what the onset is like. You must classify the motor and the non-motor at the onset. So how is the patient's onset? That decides whether it's motor or non-motor. Generalized only if it is bilateral. Now, if it is focal with bilateral tonic-clonic, that means a spread. So that was the old term of secondary generalized tonic-clonic seizures. Now it is focal going to bilateral tonic-clonic. And finally, unclassified, if there's inadequate information or where it can't be fit into any category. For example, somebody is found in his bathroom with a tongue bite and he's passed urine. You know he's had a seizure, but you don't know, nobody's seen it. You have no clue whether it's, whether it was a focal, generalized, whatever. So you just call it unclassifiable because nobody's seen it. Then awareness has now replaced the consciousness word. It's most important because consciousness is very complex. What do you mean by conscious? Awareness means you're aware of your surroundings or you're unaware. Even a kid who's, 8 months, 9 months old is aware that his mother is there. So it's very easy to understand that. And that's why awareness is what we are using nowadays. All generalized seizures have impaired awareness. So we assume there is impaired awareness, always. So you don't have to find out. So the awareness part is only for the focal seizures. And if you have a simple partial, the old terminology, now you have focal aware. And if you have complex partial, you have focal impaired awareness. It's quite simple. So you're just basically going back to the old terminology of focal and removing this partial business. Then you're classifying impaired awareness. If it is not that, if you suppose a patient is aware in the beginning, but becomes unaware later, is he aware or unaware? The answer is that any point during the seizure, if he becomes unaware, he is classified as impaired awareness. And if you're not sure, just omit this step. So then just call it focal motor or focal non-motor. If you don't know the awareness, doesn't matter. So it gives you that flexibility, which is important. Now you come to a neurologist or an epileptologist or a pediatrician interested in epilepsy. So in that situation, you want to know focal onset, generalized onset, unknown onset. You want to know the awareness state in the focal part. And then you want to know what are the different types. So there's automatisms, there's atonic on the motor, clonic, epileptic spasms, hyperkinetic, myoclonic. Many of these are new, which I will just show you later. And then there's a non-motor onset. The non-motor onset is where there's no movements as such, and it's autonomic or it's just behavior arrest. So he just becomes quiet and remains that way for a long time, only becomes frozen sort of, or cognitive or, sensories like visual or, those kind of special sensories. Then you have generalized onset. These are more or less like the older these things, but you see over here, epileptic spasms is in both. It's a focal as well as epileptic, and it's also there in unknown onset. So it's really something, which makes us think about what exactly, we're giving a lot of information of what we know, but we're also telling people what we don't know. And the other thing is non-motor onset. This is typically absence and the different types of absence. And this is, of course, motor and non-motor. The non-motor of unknown is behavior arrest. Notice the expanded classification, key rules. These are important rules. So tonic, atonic, myoclonic, epileptic. Like I said, they could be focal, generalized. And epileptic spasms could be unknown also. So you're giving a new terminology, focal epileptic spasm, generalized epileptic spasms, unknown epileptic spasms. Then epileptic spasms and atonic, you're not classifying the awareness. You don't know because it's too brief to know whether the patient is aware or not. Then all these other new terms have come, hyperkinetic, I'll show you examples, automatisms, autonomic, cognitive, emotional behavior, etc. Then focal behavior arrest. So behavior arrest, which is generalized onset, is called absence. So generalized absence. But if you have behavior arrest, you freeze up, you're not moving, you're just staring into space, but it's coming from one area, it's called a focal behavior arrest, and there's nothing else with it. And then there are new seizure types, myoclonic absence, which is an old seizure, but given a place in the classification, eyelid myoclonic absence, or this new terminology we see, myoclonic tonic-clonic, which is seen in JME, juvenile myoclonic epilepsy. And then the epileptologist might want to do a little more. So he might give little more descriptions like left, right, of course, motor, whether it's versive, the head turns to one side, whether it's Jacksonian starting from one and going to the other, which particular sensory aura the patient has, visual auras, somatosensory auras, or vertigo like a vestibular aura, or is it starting with an emotional or affective thing like fear or gelastic, there is laughing seizures, or autonomic, which is like, GI symptoms. So a temporal lobe seizure very typically has an epigastric aura, and that actually might be an autonomic seizure. And then cognitive, aphasia, all those kind of psychic, what was called psychic in the past. So the word changes are just run through them. Unconscious is impaired awareness, partial is focal, simple partial is focal aware, complex partial focal impaired awareness. This cognitive has been actually discontinued and you have focal impaired awareness. Secondary generalized tonic-clonic is focal to bilateral tonic-clonic. Arrest, freeze, pause, interruption of behavior is behavior arrest. And the new seizure types I've already told you, epileptic, hyperkinetic, automatisms, autonomic, etc. So, these are, I'm not, you can take these things later, because all these things cannot be remembered just by looking at them once. But you can, I'll share if you want it later, I can share it with you. So now let's just go with the examples and some questions. So this is a 2-year-old boy who is it coming in the way? I just play it again because I think it was coming in the way. So this woke up to find him having this attack with bilateral stiffening and shaking. And he's shaking, as you can see. So how would you classify him? First question, generalized tonic-clonic seizure, focal with bilateral tonic-clonic seizure, tonic-clonic unknown onset, or secondary generalized tonic-clonic seizure. So just give your answers fast, because then we have.
Yeah, doctor, I'll be giving a poll now with respect to Dr. Vrajesh Udani. You will see some questions, all the participants. I'm launching the poll for question 1. This appears on the screen now, and it will be there for next 15 seconds. So audience has already started voting. Nice to see. Yeah. And last 5 seconds before I end the poll and give it back to Dr. Vrajesh, please. Okay, 3, 2, 1. The poll is been ended.
So it's
And
odd.
these are the results.
Yeah. So really,
yeah, so these are the results, doctor.
Yeah, the highest seems to be generalized tonic-clonic seizures, followed by tonic-clonic seizures unknown onset, and then the focal bilateral tonic-clonic. Now, obviously, let's look at the answers. Can I remove this, please? Can you remove it?
Yeah, I have stopped sharing it, Dr. Vrajesh. Vrajesh, you can go ahead, doctor.
Oh, it's coming in my way still. I can't. I'll just close it.
Yeah.
Okay, so this is the answer. Tonic-clonic seizure, unknown onset. They woke up with the child shaking. The onset decides the type of seizure. So generalized and focal, you can't say. Secondary generalized tonic-clonic seizures, you really don't use that terminology at all. Let's go to the next patient. This is an 8-year-old. Mom says, he woke up, I felt her legs kicking me, and then the whole body was shaking. This is a cystic circus, as you can see on the right side, and there's a right temporal slowing. Let's go to so question 2. Is it a focal bilateral tonic-clonic seizure? Is it a generalized tonic-clonic seizure? Oh, sorry, God. Or is it a tonic-clonic seizure of unknown onset? I think I've already given the answer by mistake. So.
Yeah, I already started the polling, doctor. And last 3 to 4 seconds.
Everybody said the right, correct.
Yeah. So last 5 seconds to go.
Yeah, I think it's fine. I think everybody's going to say that only. So essentially means all of you have understood that the clinical is also important and the imaging also is important. So imaging tells us it's most likely focal because there's a lesion, there's slowing. And when the patient's mother sees it, it's a bilateral tonic-clonic seizure. So I think that's pretty clear. Let's go to the third case. A 7-year-old boy wakes up his mother, has left facial movements. Remember this, wakes up his mother, left facial movements. She asks him questions, but he can't speak. He starts drooling. This is coming in the way I can't read. Starts drooling, then has jerking of left arm and leg, and she keeps calling him, but now he doesn't answer. Then he sleeps again. The next morning, she asks him what happened. He said that my tongue was heavy and I could not speak. I could understand what mom was saying. So the question is, wakes up his mother, left facial movements, cannot speak, starts drooling, jerking happens later, left arm and leg, then he loses contact, sleeps, and next morning he says that I was feeling my tongue was heavy. So classify the seizure. Focal motor aware seizure, focal motor clonic impaired awareness seizure, focal bilateral tonic-clonic seizure.
So seconds have started. Polls have been responded by the participants. Last 5 seconds to go. 4, 3, 2, 1. I'm ending the poll, doctor.
Yeah.
And sharing the results to you, sir.
So the highest is actually focal motor aware seizure. But I told you awareness is if you become impaired awareness at any point in the seizure. If you lose contact, like he lost contact with his mother, it becomes a focal motor clonic, because you forget the clonic, he had movements, impaired awareness seizure. So that's the correct answer. Okay, now let's do this one. 2.5-year-old baby boy has drug-resistant bilateral asymmetric jerks in clusters on awakening. EEG is generalized discharges. So bilateral asymmetric jerks, you can see he's having the jerk now, he's going to have it soon. This is a simple one. This is the MRI. It shows a ganglioglioma. Okay. This is Dr. Nindu Desai's child. So how do we classify it? Myoclonic jerks, focal epileptic spasms with impaired awareness, generalized epileptic spasms, none of the above.
The time have started, all the participants. I'm getting the responses, very fast responses. Last 5 seconds, Dr. Vrajesh. 5, 4, 3, 2, 1. I end the poll. Over to Dr. Vrajesh, and I'm sharing the results now on the Dr. Vrajesh screen.
Yeah, so myoclonic seizures is obviously not the right answer because myoclonic jerks is, first of all, it can occur in clusters. It doesn't necessarily occur in clusters on awakening. Basically, it's more the limb muscles. This is really the head muscle was also coming in the proximal shoulder. So this is not, this is spasms. Now the question is it generalized spasms? No. The answer is no, because generalized epileptic spasms, though it has a EEG which is generalized, it's an asymmetric jerk, and you have a abnormal MRI. Focal epileptic spasms with impaired awareness, yeah, you can get confused in this, but over here, I mean, you cannot use the words impaired awareness in patients with epileptic spasms. So the answer is actually focal epileptic spasms, none of the above. Okay, it's a little tricky, that's why I gave it to you. Okay. Now, this is the last, I think. 3-year-old male, event semiology, has movements from the onset, does not respond. MRI and EEG are normal. So you can see movements of his mouth, movements of his hands, legs, especially the right side. He's not answering. His eyes are to the right. Left side is relatively immobile. Then he coughs and then he's fine. So classify the seizure. Focal motor automatisms, impaired awareness seizure, long term. I can't. Absence seizures, focal non-motor behavior arrest, impaired awareness, or any of the above.
So time starts now. I'm saying already response is coming in very fast. Last 5 seconds before I give it to Dr. Vrajesh. 5, 4, 3, 2, 1. Our poll ends here for the 5th question.
Yeah.
And over to
And
you,
yeah,
Dr.
over here
Vrajesh.
it was a simple answer. Focal motor automatisms, impaired awareness seizure. Automatisms were very prominent. It could be confused with focal non-motor behavior arrest, impaired awareness, but it is not non-motor because the automatisms are present from the very beginning. And focal behavior arrest, non-motor behavior arrest would be when there are no movements, just a frozen, like he is just, quiet and not moving at all. So I think most of you got it very easily. And then you come to the epilepsies. This is the old classification. You had all these localization related, which was essentially focal, generalized epilepsies. And if it was idiopathic, which was presumed to be genetic, symptomatic, cryptogenic, if you didn't know, etc. And this was also, used for many years, from 89 onwards. And there were lots of syndromes which were mentioned and stuff. Now, the general comments of the why we needed this was because, we have to understand that there are lots of things in epilepsy besides seizures. And which is not brought. There are lots of etiologies which have come up, which have not been in the first classification. So the epilepsies, we want to have, better classifications for communication, treatments, etiologies, risks of comorbidities, etc., novel therapies. EEG imaging information has to be used. Imaging was never used in the past. Now it has to. It's become an integral part of epilepsy workups, and multi-level classification. So this is a simple thing. I'm sure all of you have seen this, but essentially, this is the seizure type. This is the seizure type. This is epilepsy type. So this is focal, generalized, unknown as usual, comes in everywhere. Epilepsy types are focal, generalized, unknown, but one more, combined, generalized, and focal. That's a new one. And I'll just show you some, I'll not show you, I'll just tell you some examples. Then epilepsy syndromes. These are specific syndromes which have been probably properly vetted. Then after you finish the seizure part of it, you go to the etiology and look at the number of etiologies. Structural, genetic, infectious, metabolic. We'll talk a little bit about them, and unknown. And finally, you realize that epilepsy is not just about seizures, you have comorbidities, which are many. So I think I'll just go ahead. And the epilepsy type, remember, usually has generalized EEG abnormalities. If you have a generalized tonic-clonic, usually if you have myoclonic absence, they also support that diagnosis of epilepsy type. Family history is positive, you're even happier. Focal, the diagnosis is purely on clinical grounds because focal seizures very often don't give rise to abnormalities on EEG. So you have to use the EEG only as a supportive. It is not mandatory to have a focal EEG. And combined focal generalized is when you have both. So for example, Lennox-Gastaut syndrome, where you have drop attacks, which are generalized, and you also have focal motor seizures, or Dravet syndrome. I'm sure all of you know what Dravet syndrome is. Basically, it's you get hemiclonic seizures with fever in the first year of life, and later on you get generalized absences, myoclonus. You get this photosensitive seizures, etc. So that is so these syndromes can have both. That's why you're given this. And finally, unknown. Epilepsy syndromes, I won't go through this. All of you know. Just important. It could be age dependent. There's a time of onset, time of remission. Certain triggering factors may occur. For example, sleep deprivation and JME, or distinctive comorbidities. For example, some personalities in JME. Specific findings on EEG. And most important is generalized and phenotypes are variable. So you may have Dravet syndrome clinically, a phenotype, but genotype may be SCN1A, which is most common, but you may have other genes as well. Then you have changes in epilepsy syndrome. So what was called idiopathic generalized epilepsy in the past, which included childhood absence, juvenile myoclonic, juvenile absence, GTC alone, have now been called genetic generalized epilepsy. You can still use this term, but this is preferred, GGE. And instead of using benign focal epilepsies like centrotemporal spikes, you're using the term self-limited epilepsies. And why do you use that? Because we know it's an age-limited thing. They're not always benign. They may give a problem in learning, etc. And pharmacoresponsive is a new term. So sometimes they may be pharmacoresistant. So you can say a self-limited pharmacoresponsive focal epilepsy, or you can say self-limited pharmacoresistant focal epilepsy. That's equally fine, depending on the clinical. Now this is a example, benign temporal epilepsy. You can see the child is sleeping. He starts with focal clonic seizures. He appears to look at his mother, seems to be awake. Then he gets a little upset. I'm going a little forward in the interest of time. He's saying something. He's saying something, but he's not very clear. So young age, typical seizure, which is focal aware and one-sided. It has to be benign epilepsy with centrotemporal spikes, most likely. And this is Panayotopoulos syndrome, which is the occipital type of self-limiting focal epilepsy. He's seeing something, his eyes are going to the right. He's saying he's got a headache. Headache. And he wants to vomit. Ulti bhi aa rahi hai. And he's fully aware. And then he starts vomiting. I think I stopped the video there. And then there is a genetic idiopathic, what was called in the past. This is, like I said, genetic generalized epilepsies. This is the typical one which you see. I go fast because there are lots of things to be done still. And it goes into an absence seizure, a rolling of the eyes. You can't remember afterwards. This lasts for about 10-12 seconds and then recovers. Okay. And this is typically, this is a juvenile myoclonic with photic stimulation in the EEG. Hands are shaking, typically upper limbs shake more. So semiology is very important in the generalized epilepsies. They typically tell you the answer. Now going to the etiology, I've already told you of the structure, but remember you must do an epilepsy protocol MRI. Things like for focal cortical dysplasia, focal polymicrogyria, you can easily miss them on a routine MRI. So before asking for an MRI, if the patient has a drug-resistant epilepsy, it's better to send to a place and ask for an epilepsy protocol. And there are different types. There's temporal lobe epilepsy protocol, there's cortical dysplasia protocol, etc. And the basis could be either. You can have a genetic etiology, structural, or acquired, or both. For example, tuberous sclerosis, which is genetic and structural, both. So then the genetic is, of course, most of the epilepsies which are genetic in nature, many of the epilepsies, but most of them have normal genetics. Some of them have these what are called de novo mutations, or new mutations, not seen in the parents, happens only in the child. And these are usually the children, the babies who are with early epilepsies. Luckily, they are not very common. Then you come to the infections. This, of course, you don't consider infections in acute infections like meningitis or whatever, acute symptomatic or acute provoked seizures. But the epilepsy which develops later, SSP, NCC, etc., can be considered. Metabolic, you have B6 dependent seizures, GLUT1, you have NMDAR, the immune, unknown, and this may be a significant group in resource poor nations. And finally, you come to the comorbidities, and this could be very mild, like it's a mild learning disorder, ADHD, or it could be severe, autism, ID, etc., which could be part of the epilepsy or could be separate. And you can have systemic comorbidities. Migraine can coexist with epilepsy, sleep abnormalities, OSA, and a lot of other things. And finally, the last thing is on developmental encephalopathy. We all know what epileptic encephalopathy is. It's when the EEGs, changes, etc., are the ones which are causing the regression in patients. But there are some patients who are developmentally also abnormal before the epilepsy starts. So those are called the developmental epilepsies, which are effects of acquired or genetic defects. And the associated epilepsies may, of course, make it worse. So you can use either EE alone or DE or EE. Okay. So summary is long overdue classification of seizures and epilepsies. Advances in imaging, genetics, neuroimmunology have been incorporated in this. Very good. Seizures now can be classified at different levels. Even the epilepsies can be classified at different levels: GP, pediatrician, neurologist, epileptologist. But the most important thing for our nation, you have lack of expertise, you have lack of equipment, you have lack of imaging, and you may increase the unknown category. Of course, MRIs are now becoming more and more available, but still many patients will be called unknown. And of course, the most important thing is it took 20-25 years before grand mal and petit mal went out of the lexicon and we started saying, generalized tonic-clonic and stuff like that, absence and stuff. And this will take another 20 years, I believe, before the world changes its terminology which it uses. And that's why I think this should be disseminated. Okay, I'll stop over here and tell me what you want me to do. Go to the next. Next is just a video quiz.
Go to the next video, please.
Okay.
It was fantastic lecture, sir, and I'm sure it has raised so many questions as well, so which we'll answer at the end. But yeah, please go to the next, sir, please.
Yeah. Now I'll share the screen again. Sorry, yeah. One minute. Okay, so this is a little different. I thought enough talk on theory and all that, and I think it's important to know, about all these things. But we need to also, let's see if it, get these right or wrong. Now this is going to be a little tricky because it's very difficult to be interactive, and you can't keep polling every time because it'll take too much time. So you just answer on the chat, and then there are 2, 3, or 4 or 5 questions which are where you can take a poll. So I think let's try. If you just answer on the chat, I'll put the chat up so that I know.
Sir, please share the screen. We are not able to see the slides. Yes, fine.
Okay, now I'll just put the. Where's the chat? There's no chat now. Oh God.
It is there, sir.
No, in my thing is gone. I only have question answers.
So we can speak out. That's not an issue. The answers or whatever.
Okay, so you can tell us where I don't have the answers. Okay, so let's go to the first one. So mimics of seizures are very. I won't tell you much theory, but they are very common, especially in young children, and they're mainly physiologic and not so much psychological, which you see in adolescence. So let's see jerks. So I've classified these things into different types of symptoms. So the first one is jerks. Okay, let's look at jerks. So I'm giving you about 10-15 seconds to look at this. This is a baby. Somebody is saying not getting the screen. Is it right? Right?
No.
It was old, sir. We can see the. It's
okay, you can't get the screen. Okay, and also the second one. So you have to answer which is epileptic and which is non-epileptic. That's simple. I mean, it's a simple question. I'm sure most of you will get it. What are they saying? Most of them are saying what? A and B? What is A? What is B?
Most of people are saying A epileptic and B myoclonus.
Anybody can tell us what it is?
A is epileptic.
A is epileptic and B.
What type of epilepsy?
So that's it's jerks. That's what someone has written.
So myoclonic jerks, okay. So this is epileptic myoclonus, non-ketotic hypoglycemia as a diagnosis in this first baby. And you can see what is the basic difference is one is awake, one is asleep. Otherwise, even the other one he's sleeping and he has benign neonatal sleep myoclonus. So essentially, this is fairly simple. Okay. Now let's ask the question. What is not true about benign neonatal sleep myoclonus? This is something I'm sure all of you could get the answer. So
I'm launching the poll, doctor, now. This is the question for the poll.
So benign neonatal sleep myoclonus happens only in sleep, improves with clonazepam, midazolam. It can persist till 6 months. Developmental prognosis is excellent. So what is not true? What is not true?
Okay, participants, last 7 seconds to go before I give it to Dr. Vrajesh. 7, 6, 5, 4, 3, 2, 1, and polling ends here. And over to you, Dr. Vrajesh. I'll share the results as well.
Yeah, so what is not true, and most of you have got it, that it improves with clonazepam and midazolam. So this is an interesting thing because usually all jerks, myoclonic, whether they're epileptic or non-epileptic, they get better with midazolam and clonazepam, the benzodiazepine. But GABA, so these are all GABAergic drugs, but GABA in the early part of life may be actually excitatory rather than inhibitory. So when you give phenobarbital or clonazepam, etc., you actually may make this jerks worse. So that's why you should not, you should diagnose this correctly. If it's benign neonatal, nothing has to be done. It can persist till 6 months. I mean, I had a patient, I remember, went on and on, wouldn't stop, and she was getting frantic. She was a doctor's kid, And of course, I think it happens only in sleep. That is correct. It happens only in sleep. And that's the main reason you can find out whether this is benign or not so benign. Let's go to the next question. Next one. This is also quite simple. She's getting a cluster. He keeps doing it again and again. He's very happy and playful. There he goes again. Little more than 2-3 seconds. There he goes again. Actually, he's quite stiffens quite a bit. And this is, I'm sure all of you will get this also. So the first is A, the second one is B. What have most people answered?
I think A, people are confused between the shudder and spasms. So there's mixed response. And B, everyone is clear it's a epileptic spasm.
All right. So epileptic spasm is clear. This is clearly shuddering. So let's continue this. The shuddering attack, if you just look at it, it's a little more than a spasm. It doesn't seem to affect the neck or the body so much. He seems to be very happy. In babies who got spasms, like the head or the upper chest, very often the axial muscles are involved. So even the ocular could be involved, eyes. But in general, this tonic, when you shake like this, it's and you're happy and you're playful and it goes away and it can be in clusters. It is most likely shuddering attack. Now, what is shuddering attack? What type of what kind of phenomenon is this? And the answer is quite, it's actually a stereotypic behavior. So the same thing gives the child pleasure, baby pleasure, and he keeps doing it, Now, rarely, I've seen this, but some children like this, when you follow them up, they have this few autistic features. So remember, when you see this, give the advice to the patient, nothing will happen, he'll be absolutely fine. You do an EEG, of course, just to calm their nerves, everything is fine. And then you tell them, don't avoid screens and do more interaction, because you never know, this might be a harbinger of autistic disorder later. Oh God, this I already got it. Anyway. Why am I doing the mother? You tell me later. Okay. And this is another one. So what do you think? A is what? B is what? What are the answers?
Sir,
Rating,
A, people are saying it's hyperepilepsia,
Correct.
non-epileptic, and B, not sure. It's,
non-epileptic versus reflex myoclonus.
Ah, correct. So reflex myoclonus is correct. Reflex myoclonus is correct. Look at the difference. When you tap the nose, it happens, but there's jerking. What happens is this hyperreflexia is a startle disease. So you just see one jerk. Over here, the arm also shakes, the whole body also shakes. Now, reflex myoclonic epilepsy or reflex myoclonic seizures like this are very rare, but I thought I'd show one which is epileptic, so you will realize the difference. Okay. Now, let me ask the next question. Again, a poll question. These are true of hyperreflexia except one, genetic glycine disorder can be fatal. Symptoms often worsen as age advances. Drug of choice is clonazepam. I think I'm sure all of you will get it. It's quite
Yes,
simple.
doctor, it is on the screen now. As you said, the polling has already started by the participants.
These are true except, except. Remember, the most important is except.
Yes, you need to accept as said and reinforced by Dr. Vrajesh.
That means what
Accept is the term.
what is not true.
Yeah, what is not true? True, sir. Last 7 seconds to go before I stop the polling. 6, 5, 4, 3, 2, 1. The polling ends here.
So the question is, one, can be fatal. Well, let's go to the answer. The answer is number 3. Symptoms often worsen as age advances. Symptoms often improve as age advances. That's what I was doing the mother, because sometimes you have autosomal dominant. The mother may have had it at birth, may not have realized it, but she may still have a little bit of that. Of course, it can be autosomal recessive, and the autosomal recessive form is much more severe and it can be fatal. So if you stimulate them at birth, you may actually get what is called a tonic kind of stiffening, so much so that you may compromise respiration. You can actually kill the child. And if that happens, you know, everybody knows about the Vibegano maneuver, where you just flex the head and the feet together, and it is basically aborted. So remember, it can be fatal. You can get HIE because of this. It is a genetic glycine disorder, and the drug of choice is clonazepam. But as you grow older, very often you don't need it. Okay. Now, this is one child, different. I'm showing you all the. This is a young girl. This is there for the last 3-4 months, and it was to go on like this for a while. Any idea what this is? Let's go to the next one. This is a poll question again. Myoclonus, non-epileptic attacks, pseudo seizures, tics, or stereotypies?
Yes, Dr. Vrajesh, polling has started and I'm seeing responses from the participants coming in. Okay, as I said, last 7 seconds to go. 7, 6, 5, 4, 3, 2, 1. The polling ends here.
Yeah, well, actually, I'm sorry, but this is actually the answer is tics. Now, I agree with you. There is, you know, it can be it can be non-epileptic attacks. You know, this is not. But in non-epileptic attacks, it's a little difficult. You don't get different types of non-epileptic attacks in the same patient, usually. So the child basically, over here, she had one neck movement, and the other one was some bum movement, and the other one was a pelvic thrust. So it is a little different, but it could be a non-epileptic pseudo seizure. For this patient, of course, we had We thought of tics, we treated it, and the one way you can tell them is stop it. And if they can, and it comes back with a vengeance when they stop listening to you, then you know it's probably tics. We gave her, she's a very severe form of Tourette. Remember, Tourette can occur any movement, anywhere in the body. I've seen in the eyes, I've seen so bad in the spine that one patient actually had a spinal cord compression because of that. Stereotypy is usually one type of movement. Over here, there were different types, so unlikely. And myoclonus, of course, all of you agree, is not there. Now, this is another little tough one. Both these patients came with regression. Let's look at the hands, please. A came with regression in walking and stuff, but she was still, and B came in, she had some delayed speech, but she had regression in walking, and B came with similar. Oh God, I can't start it again now because this is coming in the way. So this is, oh God. Anyway, what is the answers? What everybody has said? Nitish?
Yes, sir. So A, someone has said, I mean, slow myoclonus. And B, I think still people are not clear. Perhaps we can play it again, sir. Video B. Okay, now if it runs. If this thing keeps coming and I can't play it because of that. That's fine, sir. Okay, sir. So basically, slow myoclonus, that's someone has said.
Well, it's not really slow myoclonus, it's distal. It's erratic, it's happening anyhow, and it's myoclonia. And this child has neuronal ceroid lipofuscinosis. So any gray matter disorder will give rise to this. Even Angelman syndrome can give this kind of picture. If you look at this fellow, it's very fine tremors of the hand. They're a little more rhythmic than this child. And this is a child with spinal muscular atrophy who has polymini myoclonia. Of course, clinically, you won't mistake the two. But it's important to know that certain movements, myoclonus, the point to show this was the myoclonus can come from anywhere. This is a cortical myoclonus. This is a peripheral myoclonus. You can get a peripheral myoclonus. This is like a polymini myoclonia kind of picture because of fasciculations and other kind of twitches which occur in muscle of denervating disease. So you get SMA, you can get peripheral neuropathy. Then myoclonus can come from the subcortical regions. Typically, which one? Anybody knows? SSP. So SSP is not epileptic. And that is a slow myoclonus. It's periodic. I wish I had put one example, but I don't have it right now with me. So basically, it's periodic. And if you check, it's not epileptic. That's why whatever treatment you give epilepsy, that myoclonus doesn't go, except maybe Tegretol, but that also is not often. This is what I'm saying. Okay, so I think let's move on. So I finished the jerks. Now I think enough. Let's go to generalized or focal motor, clonic, tonic, whatever. Now, this is a simple one. So he's crying. Stops crying. Becomes quiet. Becomes unconscious. Arches. Some clonic jerks. And restarts crying. Diagnosis is simple, right? So just tell me what it is.
BHS, that's written by a few people.
But is it? Yes, it's BHS with a reflex anoxic seizure. Okay, so this is a seizure which happens because of anoxia. And anyway, let me go on this. What is not true in breath holding spells? It worsens with hypocalcemia or iron deficiency. What is not true? Anti-seizure medications do not help. Rarely precipitates seizures. and no relation to syncope.
So yes, doctor, the poll is on and I'm seeing participants responding. Very nice response rates as well. So as said, last 7 seconds to go for 30 seconds. 7, 6, 5, 4, 3, 2, 1. I end the poll and give it to Dr. Vrajesh, and I'm sharing the screen and sharing the results as well to Dr. Vrajesh. Over to you, doctor.
So the answer is correct. There's clearly, it's a related to syncope. In fact, it's thought to be a syncope of infancy. Many children, when they grow up, they develop, some of them at least develop syncopal episodes, or the family history of syncope may be there. Anti-seizure medications usually do not help. And in fact, the only one which may help, if at all, is piracetam. But that also has not been proven. Obviously, all of you agree that iron deficiency and hypocalcemia you should treat as an improvement to improve the seizures. And rarely precipitate seizures is actually not correct. You can get seizures with breath holding spells. You can actually get non-epileptic reflex anoxic seizures, or you could get epileptic discharges, which can be precipitated. I had a beautiful video which I could not find, where there's a child who had a hemimegalencephaly, and whenever she would cry, she would first go into a breath holding spell, and then she would get a full-blown focal seizure. So it's really, I mean, it's useful, but always remember that most of the times it's very benign and doesn't cause any problem. The next one, this is a child, infant. Look at the tongue and the lips, please. And this is an older child with this tongue movement as well. Okay, epileptic or non-epileptic, tell me.
Yes, sir. So people have said A is non-epileptic, and they have written it's ITS, infantile tremor syndrome, etc.
Correct.
And 2 people have said it's tremors. Sorry, it's epileptic, and few have written EPC, query Rasmussen's.
Yeah, perfect, perfect. So I think the only, for those who may not have realized, if you look at the tremor, let me just put the sound off. Huh? The sound off, see, if you look at the tremor, it's basically rhythmic. There's no slow and fast. It's, you know, and this is sometimes will help you in other conditions as well. While over here, it's a fast slow. So it's clonic, really, clonic myoclonic. So EPC, correct. Simple, but I thought this is a good, nice example of this too. Of course, the other patient also had, if you remember, if you could see the hyperpigmentation, which was obvious. These are drop attacks. Over here is A, B, and C. So you have to answer 3. I'm sorry, but these are different patients, obviously.
Okay, sir. So people have said A is a small baby falling because of a voice. So it's a voice attack or auditory drop attacks. B.
So it's basically a reflex, auditory reflex seizure. Yeah.
B, non-epileptic, it's syncope. I think people might have seen that video, I don't know. But non-epileptic, B.
What is it? What is it called?
It's a syncopal attack.
Yeah, but what is it called? It's called a convulsive syncope.
Convulsive syncope. Okay.
So if you look at syncope in general, about 25-30% have convulsions. So when you have a history, it's very difficult to tell. If somebody was standing, fell down, started shaking, most people would say you had a generalized tonic-clonic seizure. So you have to look at the antecedents of the syncope. Always occurs in the standing position. The age is usually adolescence, more in girls, happens with migraine, you're sick, you're got fever, not drinking water properly and stuff like that. And of course, a family history. So, and you get an aura always. Remember with syncope, you get some feeling before you get the syncope. So if you can, the background in history is more important, and ask the parents and what did they see, whether she become cold or whether there was change in color and stuff. Anyway, this is the last one is?
Non-epileptic.
Yeah, so this is non-epileptic. Can't hear.
Yes, non-epileptic. C, non-epileptic.
What?
It's not psychogenic, but
yeah, it is psychogenic actually. It's a psychogenic or non-epileptic attacks. Yeah. So this is an 8-year-old girl, frequent falls while she's standing, having walking difficulty for 4 months. Very straightforward. So is it SSP, is it epileptic negative myoclonus, is it Lennox-Gastaut or myoclonic tics?
Poll has been launched, doctor. It has been launched, and I've started getting responses from all the participants. Very high response rates. Okay, so last 7 seconds, as we always do, dear participants. 7, 6, 5, 4, 3, 2, 1. Our poll ends here, and over to you, Dr. Vrajesh. I'll be sharing the results
Yeah,
now.
I got it. So basically, there seems to be a little, all over the place, or everybody seems to be, could be any of these three. SSP, unlikely. The jerking is not periodic at all, and doesn't seem to be. Lennox-Gastaut syndrome, even less likely, because they have tonic attacks more than myoclonic. So they have tonic drop attacks. They just fall like a piece of wood. Myoclonic tics is very rare and usually affects one part of the body. This is, of course, epileptic negative myoclonus. Now, just to tell you what negative myoclonus, positive myoclonus is what we normally see. We see a movement which is against gravity or something. But in postural muscles, like for example, if you're raising your hands like this, or if you're standing, or if your feet, you have these anti-gravity muscles which have to be continuously firing. So a negative myoclonus, we actually inhibit the firing. So epileptic discharge occurs and the firing of that muscle is inhibited. So if it happens in your leg, for example, you will fall. If you both your outstretched hands, one hand will come down or both hands will come down. This is very typical epileptic negative myoclonus. It's very common in benign epilepsy of childhood. Not be common, but it can occur in benign epilepsy of childhood. It can also occur in HIE and other conditions, symptomatic cases. So essentially, this is something you should know. This is important. Now, last one is abnormal behavior and complex motor. I'm sure this is also very simple, but let me just show it. Okay, it is the night time. Boys crying, pissing in the pot. He's talking also. He's washing his hands. Then he's still walking around agitated, crying. So there's no tonic-clonic movements, it's just abnormal behavior. Okay. And this child also got up from sleep. Okay, so I'm sure everybody's got this. What do you all think?
Yes, sir. So first A, people have said parasomnia, night terrors,
Correct.
and number B, epileptic, frontal lobe seizures, hyperkinetic seizures.
Fine. So hyperkinetic seizure is the right answer. And obviously it comes from certain areas of the brain, focal, frontal lobe seizures, etc. Night terror is a disorder of what type of sleep? Everybody can tell me? Anybody can tell me? Because they have no recollection of it.
NREM, non-REM.
Sorry?
So,
Non-REM and REM. People are saying both, but basically it's non-REM.
most of people have said non.
Yeah, so once that's why it becomes REM behavior disorder also can occur in children, but mostly it's common in adults, in older people who have much more REM sleep than younger people, and they get this REM behavior disorder where they act out their dreams. But this is obviously sleepwalking, sleep talking, everything is essentially because of. Well, I think this is the last two, maybe. Everybody knows this. You can say it out right now. This is Dr. Neeru Desai, and this is another one. Both are abnormal or motor complex behavior.
A, self-gratification, non-epileptic, self-gratification. B,
And now he's fine,
yes.
walking around. This one gets upset if he's okay. So I think everybody's getting it, gratification and paroxysmal dyskinesia. I think that was pretty simple. What happened? Okay. Are sorry. Remember paroxysmal dyskinesia. Anybody can tell me which metabolic disorder can cause it? Which metabolic disorder can cause this? GLUT, yeah. So obviously, this is very simple.
Yeah, good.
DOPA is, I mean, unusual. DOPA deficiency, unless you're talking about too much DOPA, but that is drug induced if you give it to somebody who's getting DOPA and then may get it. But otherwise, yes, most of the times GLUT1, not this type, it's called the paroxysmal exertional dyskinesias, which is more likely in GLUT. But it can occur, this also can occur in children. Eye movements. Tell me what this is, then I'll go to the next one. So this group is very good. Mr. Rathod keeps answering correct. So yes, these are ocular spasms. So it's epileptic clearly. It's well, you could say the ileal myoclonic, but ileal myoclonic is continuous. These are periodic. If you just keep watching it, even the arms move a little bit and the eyes close together. So any axial movement and proximal shoulder, typical spasms. So that's why you do a video EEG to find out if the spasms are really gone, because these can be easily missed. This is what, now I'll stop this. So the first one is epileptic. Only one person has answered. Only two people are answering. Ritesh and Nishant. Benign paroxysmal tonic upgaze, somebody said. Oculogyric crisis. See, I made him stop doing it, then he stopped. Then as soon as I said do it again, he does it again. So these are ocular tics. They're completely controllable. He's not the right age for paroxysmal tonic upgaze. Tonic upgaze usually comes at much younger ages, and they are not controllable as far as I know. So these are tics. I made him stop and he's completely suppressing them. And then he comes, okay. Well, I think I'll just go to the next one. It's not moving. Okay. Now, what is this? It is very short one. So this is typical. Everybody knows what this is, right? Epileptic, non-epileptic. One is oculogyric. Somebody's mentioned PTU, non-epileptic. Everybody agrees. Is somebody said Giron syndrome? Well, this is not Giron syndrome. Giron, remember, is myoclonic of the eyelids. This is not. This is moving upwards. Opsoclonus. No, this is not opsoclonus. Opsoclonus is a chaotic, random, intermittent, conjugate movements of both the eyes, any side. And usually this is only going upwards. So I agree it can be sometimes confusing, but this is it's not ocular bobbing either. Ocular bobbing is not this. Ocular bobbing goes down and comes up, and it's obviously seen not in this kind of state. She's a normal healthy patient. So this is actually paroxysmal tonic upgaze. So it occurs in young infants. It can be a little delayed, but usually they are normal. They have this brief rolling of the eyes and goes away, in a few seconds and keeps occurring. And generally it's pretty harmless and self-limiting and goes away. Some people think it's a type of dopamine deficiency. So people have treated with syndopa, levodopa, and they found some results with it, though frankly you don't need to do anything. And this is anybody? Nobody? Everybody's forgotten? What happened? Yes. This is a child with oculogyric crisis. And whenever you see this kind of thing, remember you have dopamine deficiency. And dopamine deficiency. So anytime you block the dopamine with psychotropic drugs or domperidone or metoclopramide, or if you basically have a deficiency syndrome, genetic like a neurotransmitter disorder, this is what you get, oculogyric crisis. And remember the baby is very upset, very, very, irritable. So I think generally, staring spells, I have a video, but it's not playing, so I'll leave it. Basically, the only thing I want to tell you about staring spells, it looks like a behavior arrest. It could be absence, it could be a focal behavior arrest. But importantly, it can also occur very commonly in children who are autistic, who are retarded, because they just sort of stare into space and then for some time and everything is non-epileptic. Why they do it, I'm not so sure. Nobody really knows. But this is something which also you must consider in physiology. So non-epileptic attacks constitute about quarter to half of all paroxysmal episodes in children. Remember, these are from places which have clinics, especially for first seizure. Physiologic movements, benign movement disorders are more in young children, while syncope, non-epileptic attacks, and migraine in older kids and basically in adolescents. Obviously, home videos, VEG. So before labeling, please be very careful. I think I've given you a sort of just, I know most of them are easy. Most of you know all this, but it's better to just revise it. Okay, I hope you enjoyed it. I mean,
thank you, sir, for a wonderful presentation of common conditions with very wonderful videos. Very big basket of wonderful videos.
Okay, any questions or no questions? There are some questions, I think.
I'm going to read out one by one. So what is the meaning of probability of further seizure similar to the general recurrent seizures?
I'm sorry?
what is the meaning of probability of further seizures similar to the general recurrent seizures?
Correct. So in epilepsy, in epilepsy, generally, when you have a first seizure in a patient, your risk, of course, is different depending on what it is. But if you have a single seizure, a normal patient, your risk is about 30%. And most of us will agree that you don't require treatment. You can't, it may not happen again. So there's a 70% risk, chance that it won't happen again. In epilepsy, usually that risk doubles. And because it doubles, that's why we call it epilepsy, because we basically want to know whether this is going to recur or not. So if in the first seizure itself, if the probability is decided by the imaging or by the story, or the patient has a hemiplegia or something, even the first seizure and he's got abnormal EEG, MRI, then it's very likely this patient is going to recur. That's why we call it epilepsy from the start. So you be justified in calling it from the start.
Yeah, again, you have explained in your presentation, but they want to know difference between unknown seizures and unclassified seizures. Difference.
Unknown and?
Unclassified.
Yeah. So unknown is when somebody sees the episode, but is not really seen the onset, which is very common because people don't usually see the onset. In adults, unclassified is much more common because they're alone, living alone. They may be at work, nobody has seen them. And then they have a fall or they have some sort of, and people have not, so you really don't get a description. Or it could be something which is not fitting in. So you have a seizure which is not fitting into focal or generalized, you're not sure. So it's a seizure, but you can call it unclassified.
Yeah. Third question, as you mentioned, role of importance of home video in classifying the seizures.
It's very important. It's very important. But remember, one of the disadvantages is that you don't get the onset. So very often they don't get the onset. So the history has to be there. Did you see the onset? Did he come patient, aura in a baby or a young child? Either he comes to the mother, clings to the mother. You may not know what is actually, what sensation he's getting. So you can't classify it as a sensory seizure or some cognitive seizure or something of that sort. But that something has happened, and that will tell you it's a focal seizure. Yeah.
Age of onset for epileptic spasm, can it occur after 2-3 years of age?
I'm sorry?
Onset of epileptic spasms.
Yeah. So majority of them occur below the age of 1 year. And but there's something called late onset epileptic spasms, which can occur later, usually by 2-3 years of age. And persistent epileptic spasms can be seen very commonly. In fact, these very children who are very disabled, like hypoglycemic brain injury, they can continue to have epileptic spasms all their life, and Aicardi syndrome and stuff like that. So it is definitely can be persistent. Onset is usually before 1 year, but sometimes can occur after up to 2 years, 3 years also. But remember, often the patients have missed the onset. That's why they may say it happened afterwards. Very difficult to control if it is late onset.
An interesting question: how to differentiate parasomnia from complex partial seizure? Now
there's a score. It's a very nice score, but generally parasomnias, like the most common is night terrors or sleepwalking or whatever it is. They appear to be partly aware. They talk a lot. They don't have the same stereotypic thing as long. So the night terror, how long it was. The whole video they've taken, it almost lasted for about 5-6 minutes. Most seizures, on the other hand, are stereotyped when they occur in sleep. They are the same looking every time, more or less. They are much shorter. And, so that is the way. But there is a score called the FLEP score. I think it's FLEP, where you can actually look it up and it gives you a FLEP, FLEP, and you can actually give scores to, all that. And then you can come to a score. If it is less than this, it is more likely to be parasomnia, otherwise a seizure.
How you classify seizures where there is a uprolling of eyeball and loss of tone and loss of awareness?
Well, if you have uprolling of the eyeballs with just a drop, correct? You're talking about an atonic seizure. But it's always difficult to know when a person drops, whether his body has become stiff and he's dropped, or whether he's become loose and he's dropped. So the one thing which helps me in my practice is if he falls on his head, that is because he's become tonic, he's become stiff. So when he becomes stiff, you don't have any, you first fall straight on your head, and Lennox Gastaut is typically of that. Doucet syndrome is myoclonic atonic seizures. So atonic seizures, typically they fall on their bum. So if you have lack of head injuries with lot of drops, then it's likely to be atonic seizure. Of course, very difficult to tell. Third thing is, remember, even focal seizures can have slow drops. So they don't really injure themselves, but when they fall, they don't fall suddenly. They fall a little slowly. So they usually protect themselves. But even a frontal lobe epilepsy can fall, a temporal lobe epilepsy can fall.
Yeah, another question. What is the new or defined definition of refractory epilepsy, considering number of AEDs and timing of the continuation of the epilepsy?
So the ILAE is actually given this two-year rule. So 2 anti-epileptics, 2 years in alone or in combination, I mean sequentially or in combination at appropriate doses, etc. You call it drug resistant. But the problem with that 2-2 rule in children is, the reason why is it defined? Because you want to know whether a patient needs surgery. So if you refer to a center like ours where we do surgery, we want to make sure the patient is resistant. Now, if a patient is a 6-month-old, you can't wait till 2.5 years, because by that time he'll become intellectually disabled. So a young child, this timing may not be as this thing.
Yeah, just can you elaborate some important features of Doucet syndrome?
See, it's a genetic epilepsy. Often it has febrile seizures. It starts off with febrile seizures. Then usually you get these drop attacks. And like I told you, the drop attacks don't result in as much injury as Lennox Gastaut syndrome. They usually are normal kids. They are not retarded kids or delayed kids like very often LGS is. And they have basically other types of seizures, typically absence. Now, like Lennox Gastaut syndrome, one of the similarities between them is that they can go into absence status. And, sometimes Doucet syndrome doesn't do as well as people think. The best treatment for Doucet is actually ketogenic diet. It's the most effective treatment for Doucet syndrome, the ketogenic diet. I'm not suggesting you start it straight off, but in a patient who's not responding to valproate or lamotrigine or all these kind of drugs or clobazam, etc., you should use this particular drug. I mean, per diet as soon as possible. Remember, sometimes Doucet's can be the presenting feature because it's seen around 2-3 years of age of GLUT1 deficiency.
Yeah, you should keep in mind. Do anti-epileptic have a role in convulsive syncope?
No. And the short answer is no. It's just a anoxic kind of seizure. So basically, you have to just drink a lot of water and sleep properly.
How to differentiate absence seizures versus blank stare seizures in a patient of autism?
I'm sorry? It's a little difficult. It is difficult, and you may have to do a video EEG to actually confirm whether it's actually a staring spell or a blank spell, but whether it's just a blank spell. But essentially, if you usually seizures, if you call out to them, most autistics obviously won't respond. But if you shake them, usually they will respond, with some pushing you away or something. Absence, on the other hand, if you touch them also, they won't usually respond. So that's the one, but it's not always 100%. Believe me, you can be fooled.
Yeah. Is there any treatment for self-gratification disorders?
You don't need to. It's another stereotypy. It's like it's pleasure. And now why it gives pleasure, people have called it infantile masturbation and all that. But if the parents are very upset by it, which I try to counsel them and nothing has to be done, but it starts off sometimes, this is my own observation, it sometimes starts off with vulvitis, redness, diaper rash and all that. So at that time, because of the rash, the kids, itch, and then the pleasurable sensation comes. So I would always look for that, and then becomes a habit. So you look for that. If there's any evidence of that, use usual sitz baths, methadone baths and all that for vulvitis. If that is no reason, then just ignore it. Just distract the child.
In a developmentally delayed child, if they have excessive startling to the sound, what is it? Should be treated, what do we consider startle-induced seizures?
Yeah, so startle is an interesting thing. So one is, of course, there's a startle reflex, which all of us have, but which seems to be much more in children with hypereplexia, in children with bad diseases like Tay-Sachs disease, Krabbe's disease, etc., leukodystrophies and lysosomal storage disorders, and also in children with cerebral palsy. And they have this kind of drops. Sometimes the drops actually may not be, maybe actually a startle epilepsy, a startle seizure, which is usually seen in children with hemiplegias and CP. And they are very difficult to control, very difficult to control. But the way you can tell is that in a startle episode, just one jerk like this, while the startle epileptic seizure goes on for a longer period of time.
Sir, that's excellent presentation. Lots of questions still coming in, but I think we are near to the ending time. So, sir, first and foremost, thanks to you for this fantastic knowledge sharing. And that's a theme for sharing and learning. And it helps us all to learn from you and improve patient care, and hope it helps everyone. So we also thank all the participants for spending nice time. And that was again very helpful and very essential that we get lots of questions, lots of interaction from them, and you made it so interesting. So that was again very helpful. And so again, this is not, this is still just day 2. And we are seeing lots of things happening. So,
Okay.
So, sir, day 3 tomorrow, we are expecting Dr. Anita Hegde to help with the decision time that's choosing the right AEDs. And then day 4, the final frontier approach to drug resistant epilepsy. So just wanted to request them that it's learning and sharing, and we do maximum whatever possible here.
Okay, thank you very much. I really enjoyed myself too. Thank you very much. It's been a great audience. Thank you.
Sure, sir. Thanks a lot, sir.
Bye-bye.
Bye.
Have a good night. See you.